I've been involved also in economic evaluation of this program, and currently working on the endline data analysis. And there are plans for operational research and even mobility studies. And the whole idea behind the M&E plan is to ensure that we've got evidence for decision making. We're generating data that will support decision making. So what were the goals? Like I've mentioned, we want to see the impact, or we see the changes that are happening at the health facilities where we are focused. It's been said variously yesterday, or emphasized, that the interventions are going on in selected health facilities across the countries where we work, and the M&E definitely is based there. See the changes there. We want to see if we can identify areas that need support, areas that need to be flagged up for more attention or for changes. We also wanted to provide information for decision making, and this cannot be overemphasized. And then hopefully to assess the impact of interventions at every stage. So what we did was that we, of course, initially had the baseline health facility assessment that was conducted at different times in the countries because of the differences in the onset and the time in which the program was begun. And this was done to understand the context and to support planning for implementation. In Nigeria, the baseline facility assessment was conducted in August 2020. In Kenya, it was in 2021, and in 2022 in Tanzania and Zanzibar. And we carried out a before and after comparison of the baseline findings with quarterly data. And this quarterly data is what my colleagues are going to be showing you in a few minutes, compared to the baseline. Collected using a survey CTO that we developed, electronic forms, of course, on the usual platforms of mobile phone and tablets. So there was a quarterly data collection that is still ongoing, and we've got two that we've analyzed, we'll be showing you soon. And then, of course, these are routine data that are aggregated across all participating healthcare facilities. So how did we select the indicators? We reviewed existing documents and published studies. I'm sure this is the standard approach that everyone does. And then we focused on quantitative indicators, ensuring that the indicators we are selecting are standard and will allow us to compare our impact or compare performance globally. And in particular, we took notice of indicators that contribute to the targets of ENAP and EPMM. We discussed this with Charles, the unit lead, and we refined and agreed indicators across the country, passed them on to the data manager, and all the data were collected from health facility registers and records when our colleagues went to the health facilities and spoke with the in-charges and people who are in charge. There are several layers of indicators we are looking at. So we're looking at the ANC services, PNC services, deliveries, indicators around integrated HIV, TB, and malaria services, and then quality improvement activities. And just to show us more extensively, and when the indicators we looked at, as far as ANC attendance was concerned, were total numbers of ANC visits, number of pregnant women attending first ANC, number of pregnant women attending first ANC before 12 weeks. And for essential screening, we looked at number of pregnant women tested for hemoglobin and the numbers that were tested for proteinuria, hemoglobin, and blood glucose combined. For the postnatal services, again, we looked at attendance and essential screening. And under PNC attendance, the indicators were total number of PNC visits, number of first PNC visits within 48 hours, number of PNC for baby within 48 hours. It was interesting to hear the reps from the government talking about these indicators and how they've performed in the different countries over the years. And for the essential screening, we looked at number of postnatal women tested for hemoglobin once again, number of postnatal women checked for blood pressure. Then for deliveries, you'll be shown data on number of women who gave birth, number of live births, number of fresh stillbirths, and number of macerated stillbirths. And then for the integrated HIV, TB, and malaria services, we are looking at the 6 levels, the total number of pregnant women tested for HIV, and the number of women tested for HIV during the first antenatal care visit. And for malaria, we were looking at total number of pregnant women tested, tested for malaria, and number of pregnant women tested for malaria during first intensive visit. Finally, for tuberculosis, we looked at total number of pregnant women tested for TB, and number of pregnant women tested for tuberculosis, who tested positive, for tuberculosis, and were referred for treatment. And for QI, just the number of QI committee meetings held. I've mentioned that we collected data at baseline, and then again at Q1 and Q2 of 2023. For Nigeria, this is slightly different. There was no quarterly data collection, but there was an end-line data point. I mentioned earlier that data collectors visited health facilities on agreed days, the days they agreed with the health facility management, and were able to visit, conduct those interviews, and collect those data from the facility records using the forms that we developed, like I mentioned, the mobile phone and tablet platforms, and we'll always upload those data in real time to central server that is hosted that, managed by our data manager, and manage the usual way. But for the purpose of this discussion today, or the purpose of the presentations today, the analysis was basic descriptive. We're looking at proportions and percentages, and like I said, comparing what the situation was at baseline with what happened over the quarters. And then importantly, every data is being contextualized. We recognize that, yes, we are working entirely in sub-Saharan African context, but there is a difference from context to context. And my colleagues are going to be presenting these results in light of their own context. And they'll be sharing these results in a short while. So just to conclude, I think what we all know, we cannot do without monitoring and evaluation. And for our program, this is inbuilt from the outset. I've itemized all the areas, all the parts of it, and it's so central in every program implementation. And I think it also gives us opportunity to benchmark what we do across the world, but in particular, as we are looking at the ending at NAP and EPMM, it's important that we have this opportunity to align our indicators with the targets so we can have the maximum impact. And then we expect that the results will inform implementation, they will inform decision making and practice. So I'll stop here, and my colleagues are going to now take us through the various performances across the country as far as these indicators are concerned. Thank you very much for your attention. And then if you have any questions, I'm here to take them.
Thank you, Uzo, for setting the ground for the next presentations. I'm sure you are going to remain online, because at the end of the presentations, we'll be having a Q&A session. And if there are questions that will be directed to your presentation, we'll be ready to take them. Now I invite the next presenter. Now we are receiving results from different countries. The next presenter is Hawa Mohammed from Nigeria. Welcome.
Good afternoon. Okay, still morning. Good morning. So now I'm not a PhD student. No. This is from the work that we do in Nigeria. Good. So this is the program. Some of you were not here yesterday, but the program that we'll be running in the various countries is quality improvement in integrated HIV, TB and malaria services in antenatal and postnatal care. And in Nigeria, we implement this in Kaduna and Oyo State. So I'm going to look at some key performance indicators, some of those indicators that Uzo has mentioned. So this is the outline of my presentation. So this, just for the sake of those that were not here, we've already discussed this yesterday, but this quality improvement program was started in Nigeria in 2020, actually at the peak of the COVID-19 pandemic. And we're running the program, like I said, in partnership with the Kaduna and Oyo State Ministries of Health and primary health care development agencies. I'm sure from my last presentation you will understand that there are different agencies that take care of different cadres of health workers in Nigeria. Like Uzo has mentioned, in August 2020, after the inception of the program, we had a baseline assessment on 120 health facilities. So in each state, 60 health facilities were recruited into this program. And at that time, you know, Nigeria is one of the first few countries that